Oh yeah, I ought to say that I have no financial interest in this thing. I have no financial interest. Yes, pointer. I don't know if I'm a pointer, but that's okay. Thanks. You know, we come to this academy meeting, and probably one of the most difficult things is how do we integrate all the things that we've learned into our practice. And for some years, I have really felt that the most difficult thing is to continue to do good quality dentistry, at the same time add in all the biological things that we do. And so we don't want to throw the baby out with the bathwater, and yet at the same time when we see these patients, a lot of them need to have, let's just say, a reconstruction of their mouth in one way or another. And you need to explain that to them, and the vast majority of them you need to frame it in such a way that they can afford to get it done and still not do it in a short period of time, because financially you just can't do it that way. So how do you triage these patients? How do you explain to them what you're trying to accomplish? How do you easily explain to a patient who has a toothache that it's an occlusal issue, or they've worn their front teeth down and they need to have some longer anterior teeth to get a guidance of the front tooth and get off of the back teeth? How do you explain a clicking joint to them? And by the way, tomorrow afternoon, the last speaker is going to be Dr. Mark Piper, who is a MD DES, and he has literally bridged the gap between medicine and dentistry in explaining TMJ and occlusal issues, and has coined the phrase joint-based occlusion. And it's something you just don't want to miss, because it'll really change how you look at these things. And a couple of years ago, I'm also a life member of the American Equilibration Society, and about 4 or 5 years ago, I ran across this program at their meeting. It's in February in Chicago every year, and it just literally changed how I do things, to the point where I had a patient the very day I was back after the meeting, who I had been for 10 years trying to explain to her why we need to reconstruct the front teeth, give her some anterior guidance because of her TMJ issue and the bite issues. And with this, she got it. So what I'm going to do is kind of go through this. This is a kind of a free-flowing thing. And rather than go A, B, C, D, E, F, what I'll do is I'll go through some scenarios, and if you have any scenarios you'd like me to explain and show you how I use this program, I'll go through it to you for you, okay? And then at the end, maybe let me know with about 10 minutes left or 20 minutes left, I'll go through actually how this thing is structured. I think by that time you're going to see how it's structured. So this is a program called BiteFX. When I got it 4 years ago, it was less than $700, and it's still less than $1,000 for the program. And it literally, like I said, literally pays for itself. So let's say, for instance, you get a patient that comes into the office, you do a comprehensive exam, they've got perioproud, they've got loose teeth, they've got sawed-off anteriors, they've got headaches, neck aches, muscle spasms in the masseter muscle, temporalis muscle, and the pterygoids. They've got a broken tooth, yada, yada, yada. So let's go through a little bit. So the first thing, and as you can see, this is going to cover just about every emergency you have. It's going to cover any complex case you have. And sometimes I spend only a little bit of time with the patient on it. Sometimes I spend a lot. Sometimes I don't spend very much time. My staff spends it. And we can do, you can see the printout over here. You can give them a printout of some of the things if they want the information to take home to their folks. And even there's a provision in here where you can take photos of that patient and integrate it into the program. So down on the bottom here, there is a little circle here that allow this thing to play, or I can take, let me just do this a different way. Let me shut that off, and I'll just use my pointer and I can open and close this jaw with the jaw joint in the proper position. And I'm a pinky grad, so that's the manipulation that I use, the bimanual manipulation, to show how in a healthy mouth all the teeth should fit together. So, I got a sore tooth. So let's go ahead and click on this, and I'm going to go through the series of sore teeth. So the one that I like to use, because it's so fast and easy and I can dwell on the remainder of the ones in this whole column initially, is this one here. Sometimes I'll use the automatic cycling, but because of what we're doing here, I'm going to go ahead and do this the slow way. So we have them chew. And sure enough, if they're hitting that tooth heavy, you can show the reason why the tooth gets hot. Or why this tooth is worn down. Or why you end up with a loose tooth in perio and what you're measuring with the perio probe. Or if the bone is really solid, why that tooth may end up breaking off. The only thing it doesn't show on here is when on this particular view, is when the patient has muscle spasms because they're trying to avoid the trauma to the teeth. Doesn't that answer pretty much the scenario you have with those kinds of issues? So in this particular, find my mouse here again. There we go. So as you go down this scenario here, and I probably, the vast majority of time, somehow I go on, and here's just a single tooth. And of course, here's the explanation. It says here, this animation shows how sensitive nerve or painful teeth can be caused by having poor or no canine guidance. For example, when you move your jaw from side to side, the shape or position of your canine teeth do not ensure that your molars come apart, and it's a C animation. And then it tells you what frames are involved, where they are, and then points to note. And so if I turn this thing and talk to them and just say, so we're going to go ahead and put this on automatic, I can go ahead and do whatever I want. I don't have to pay attention to the cursor. And it just replays until you're done talking about it. So for these purposes, I'm going to do it that way. So there's the one. Go back up. And if there's a drawback to this particular version, it's a little bit hard sometimes to go up that little amount. So this is the one that shows tooth wear. Pretty self-explanatory, along with the explanation. And here's the one with perio. I happen to use an additional explanation, and I say, you know, you've all had a garden or a fence. And if you have a fence post or a stake in your garden and you push straight down on that stake, that tooth is pretty sturdy, or that post is pretty sturdy. But it doesn't take a lot of effort to move it from side to side, and pretty soon the soil starts to wash away and the post gets looser and looser. Teeth are no different. It works the same way. And so when I do the perio chart, you know, over here we had a 7mm pocket. That's what we're looking at. Here, this is the reason why it curves, or one of the contributing factors. And then, of course, if the bone is strong enough, and you'll see some of these patients that grind and they got exostosis, they got extra bone on the buccal, either on the lower or the upper, or they've got a gigantic mercury filling in there and there's a fracture on the tooth and finally it breaks off. But at the same time, you know, if you restore it to the way their mouth is now, you're just going to restore the original reasons why they have an issue with the tooth. Because how many times do you have a broken tooth but not a perio problem? You know, a lot of these things go hand in hand. So let's look at this whole idea of what normal is. And on that first section, the open and close with the muscles that I was showing you before, without the muscles I should say. The next one is open and close with the muscles in place, so you can explain, or they know that when you palpated the temporalis or the masseter or the pterygoids, what's going on and the reasons why they're sore. And what I give them a little bit of an explanation of is if you had a stone in your shoe and you were limping, pretty soon your leg would bother you, then your hip, etc. Well, the mouth is no different. If the teeth don't fit together right, you're going to hold your jaw in a different position. After a period of time, it's going to get sore. Sometimes you hold it here, sometimes you wear it there, sometimes you wear the front teeth off, etc. They get that stuff. Let's look at the next normal. With my mouse again. There we go. This is a little travel mouse. It doesn't take too much effort to get it to move all over the place. So here's the pterygoids, along with the disc assembly. And, the superior head of the pterygoid is basically connected to the disc or the meniscus, and the inferior head is to the condyle. And so, it's well known now that if you go ahead and try and reposition that condyle onto the disc in a proper position, it's probably not going to make it, because over a period of time these muscles get shortened. But the whole idea is, how do you restore that patient if you're going to restore them? And should you if they've got a click? And I'll go into a little bit of that a little later. And here's a side-by-side of the same thing. And you can even have the patient, hey, open and close your mouth, put your finger up there. You can feel the jaw. The first part of the movement is rotation of the jaw. The second half is translation down to eminence, depending on how much explanation that patient really needs. So here's opening and closing when the jaw joint is not where it's at. Remember I was talking about Mark Piper for tomorrow? He's going to talk about joint-based occlusion. Well, in this case, the joint isn't in the proper position, but the teeth fit together. And the vast majority of patients we see are like that. So where do you restore them to? The patient comes in, they got a mouthful of amalgams. You're going to do some composite fillings and or crowns or onlays and whatnot. Do you talk to them about just doing the fillings and doing the crowns, and you restore them to a position that is harmful to the teeth from a perial point of view or a TMJ point of view? Or do you say, it would be better if we would first get your mouth where it belongs? And how do you do that if you've got a mouthful of amalgams? You don't want to equilibrate on the amalgams. And that's something we don't really ever talk about. I never want to do an equilibration on a mercury filling. But whose choice is that? Well, in my practice, what I have said was, I won't grind on a mercury filling except to take it out. So if you've got a joint problem and or an occlusal problem and you've got this pain, it would be best from an engineering point of view if we resolve this before we go ahead and do the reconstruction, because then long term, in 5 years when your treatment is completed, you can then have something that is fitting together properly with the least stresses on the joint, the muscles, and on the teeth. So the next one down the list here is the side-by-side with a little better measuring idea so they can see where it's at with the muscles going into spasm. Oh, that's why I have the pain over here. And this is with the joint in the proper position and with it anterior. So since I'm on this one, I'm going to jump a little bit. And I'm going to go to this area here, effects on the TMJ and the disc. And there's only two views in here. One of them, let me shut this automatic off here and go back to the beginning. And I explained to them that, hey, when you first start to open, you only rotate. And you're not going to really hear much until you start getting into translation. But over a period of time, that disc starts to distort. And here's the clicking you're always hearing. It's when distortion starts to occur, and when you open, you click over it, and then when you're closing, you click back over it. Oh, okay. And here's the foreshortening of the muscles, why it's so difficult to get them back and recapture them. Back in the late 70s and early 80s, we used to think that we could recapture the disc. And I used to do the splints and pull them forward, recapture that disc. And after about a year and a half, 2 years, I abandoned it because you would recapture it, you'd restore them to the recaptured position, and a year later they're off it again, consistently. But at the same time, what you're going to hear Mark Piper talk about tomorrow in his joint-based occlusion is there's a good side of town and there's a bad side of town. If this is the condyle and here's the disc, if it's on the disc completely, it works fine like I'm showing you here. But if it's off on the lateral pole, you're going to have some clicking. It's when you get off on the medial pole too, you start to get the changes of occlusion. And when it gets off the medial pole, it starts to bunch up on the artery, and then you get your osteonecrosis of the joint. And he's going to probably talk about that at length tomorrow. So anyway, as we move along through here, you know, they've got a joint on both sides, and you'll say to them, hey, remember when we were looking, we said you move to the side? So they open and they go all the way to the right. Well, why are they going to the right? It's because the disc is holding them up. But if they click over it, they'll go back into the center position. Or if this advances even further, they'll end up with what used to be called a closed lock, where this bunches up completely and they cannot translate on the evidence. They'll deviate only to the one side and stop there. Or if it's on both sides, they have limited opening. They just can't get over there. And then the other one that's in this series is more degeneration of joint over a period of time, especially in class 2s where their jaw is forced backwards and they're on the retrodiscal tissues. And you start to get shortening. So, okay, patients in that kind of position, they got degeneration of the joint, you're trying to go ahead and restore them. And what ends up happening? Because of this kind of a situation here, that occlusion on that side is not going to be stable. And as that deteriorates, that bite is going to change. Isn't it nice to know that you go ahead and put the dentistry in this patient, you can tell them ahead of time, because you have this kind of a situation, or let's say, for instance, you're off the lateral pole, but not off the medial pole yet, you can stabilize that occlusion. But if you get off the medial pole, guess what? We're not going to be able to stabilize it, because you know you're going to see that patient over and over and over again. And they're going to say, I was fine until I saw you, until I had all that dentistry done. But if you can tell them ahead of time, here's the evidence, here's the proof, you know, of what's going to happen, and I can look into the crystal ball, and doing a splint and or, depending on the situation, and a equilibration, we can keep this in a safer zone so there's less probability of this kind of a thing from occurring. So let's move on to another section here. I jumped right into TMJ right away, but here's anterior guidance, okay? When you slide forward and back, you should be on the front teeth so that you can get off the back teeth and don't create those problems of rocking the teeth and whatnot. And here's canine guidance. Moving to the side, getting off of the back teeth. And how many, I rarely see an adult without worn down cuspids. We all see them all the time. You know, do we look for whether or not they're in canine guidance or group function, and whether or not there's mobility on those teeth? I had an emergency patient come in Wednesday morning, and he's got pain on the right cuspid. He's got a bridge from 4 to 11, and I have him close, and literally he closes, and you see that bridge go, meow, meow. Whoever did the occlusion had it all messed up. So you look at the x-rays, he's really got no horizontal bone loss and really no vertical, but there you can see the PDM space really widen. What was really unique, and I've never seen this before, if anybody's seen this, let me know. I had him go in the left lateral on the number 11, and you literally could see number 5, 6 lift up. Now, I have him laying back, so he goes to the left, and you see the whole bridge go, like that, come out of the socket. But I can sit back and I can show him that on here. Because of that previous one I showed you with perio disease and the loose teeth, it's easy for him to understand, or easier for him to understand. So here's some side-by-sides now of that other one that I was showing you with where. I don't particularly use this, but there are times if patients don't get it, I'll show them this. Let's go to the next sequence here, and this is contact, okay? So when they close, here's the way that you should be. You should close, and you have contact on the marginal ridges and the fossa on the cusp tips. But over a period of time, you're going to have wear on those teeth, or you do have wear on the teeth, and what really it's looking like is like this, where they go ahead and they close, and they've got flattened cusp, etc., and or broken teeth, and or loose teeth, etc. So depending on the circumstance, you can address the individual problems, or maybe just on a very selective basis. So here's the effects of bruxing. Patient opens. Put my mouse back. Patient opens. And closes. It's like forward and back. Take that a little step further, and what we'll see here is the effect on muscles. How many times we get a patient come in and they're complaining of soreness on the back tooth on number 2 or number 15, and the contact is open and they're trapping food in there. And it's very easy now to say to them, here's all that's happening when you rub from side to side, you're on those back teeth, and guess what? Space gets opened up. And you go ahead and you floss in there, and the floss has resistance going through. Well, what happens is they chew, that tooth moves out of the way, the food goes in, and then it comes back. And what about that bone loss? See the thing moving on you there? All right. Let's move to, this is one of my more favorite ones, with the wear on the eye teeth. So the patient is wearing down their eye teeth over the years. Just shears that off, gets to the anteriors, wears them down, and then when they have no more anterior guidance, they get on a bicuspid, or they'll get on a molar tooth, and they'll start to loosen, or they'll get an abfraction. Okay? Easy for them to understand. So let's go to slide. You're holding the jaw so that you know that they're not going into translation. They hit on a back tooth and they slide forward. They can feel it. I don't know about you, but we register the anterior slide, the right and left, and the vertical slide on all of our patients so we know where they're at. It's on my form. I've got one sheet form that I can chart all of the restorations according to whether they're composites or amalgams or metal. And then I've got a section for occlusion. I've got a section for muscle palpation, for soft tissues, TMJ. Okay. If you want, email me and I'll email you a copy. Yes, sir. No, you can anytime. Ask me. Yeah. Oh, yeah. Yeah. And the point I'm trying to let them know is that it could be a very simplistic solution. Just say, well, all we got to do is this. But we all know that there's confounding factors. And what I like to let them know is, yes, this is what I think it is, but there's some other issues that we have to pay attention to. They may say, hey, all I want to do is fix the tube. Don't bother with this. And you got to read body language, okay? You got to ask questions. You got to ask for feedback. It's got to be an interactive kind of a thing. But some of them will want to know a little bit more. But I have the capability now of explaining some kind of an esoteric thing that was, before I had this information, was so difficult to get across to them, where now there's visuals and they can actually feel it a little bit more, they understand a little more. They may not know it, but they know that they're hearing something that no other dentist has ever talked to them about. And you're a mercury dentist who they come to you in good faith and whatnot, and you're trying to tell them, oh yeah, you've got these corroded fillings and we know there's decay underneath them. You know, no matter how good the referral source is, they still have to do their trust kind of a thing. You know, trust is transferable. And if you have a great relationship with your staff and you trust them to do things and whatnot, they'll transfer that onto the patient. What induces a patient to come in a short period of time, commit to a 5, 10, 15, 20, not so much anymore, $30,000 treatment plan, whether it's 6 months or it's 3, 5, 7 years, but at least you now could put a treatment plan together where maybe right now they're only doing phase 1 and there's 5 phases. But what you have is you have the plan together so you don't have to backtrack later. And if there's resistance, what I will tell the patient is, all I want to do is make sure that you understand that there's other options here. I would rather do this because talk is cheap right now. It doesn't cost you anything to think about this and to consider it. But what I'd rather not have is you 2 years later, because I, on my side only, said, well, you don't need to know this information, and you say then, well, I wish he would have told me that because I would have chose this. And we've all had that happen to us. So all it is really making sure of the professional dental, conventional dental side, not the integrative side of the practice, but the dental side of the practice, that you've got informed consent. Does that answer your question? It doesn't look like I quite did. Are you familiar with Dawson's bimanual manipulation? Okay. So you do bimanual manipulation, you find out where their first contact is, and you look at the slide till they get into CR. Or CO, rather. From CR to CO, that's all I'm measuring. And I guesstimate it. You know, it might be 2 millimeters, but the point of it is there's a slide there, and they can feel that. And they got muscle spasm on that side. And so you register things like balancing interferences. You look at the crossover interferences, which for some people with head and neck pain, those are the most destructive things. So what I do is when I look at crossover interferences on my exam form, I've got light, medium, and heavy. Well, light means that when they go into crossover all the way over, that they're not touching on the working side or balancing side on the posterior teeth, and their teeth are together. If they're slightly apart, it's medium, and severe is the third one. And if they're really open, 2, 3, 4 millimeters, it's severe. Well, you don't want to have those things there. And invariably, 10 minutes? Okay, let me go through this real quick again then. Okay, I didn't realize I was going that slow. Let me pick out another. So treatments. Let's look at treatments. You can do a diagnosis splint, NTI, something of that sort, and insert it in and eliminate the posterior interference to get some muscle relaxation. I wish they had an aqualizer. They don't have an aqualizer in here. You can do a full splint. which will really protect the posterior occlusion and keep you having posterior eruption. You know, if you only had the posteriors, you can get some anterior eruption, and a lot of times you'll see that. They got the wrong kind of splint in, depending on the situation. And there's a little bit here on equilibration. So how do you go ahead and you treat this? Well, they've all had this done when they had a filling place. But you find the spot, you mark it, you go in, you dust that area off, you go back, and that spot's okay. But now on the other side, you got another spot. And you go until you've got these things fitting together the way we showed you before with the point contacts. And we'll go back to that spot, you know, where you can see all the teeth in the lower arch. Let's see if there's another one here. This is effects of interferences, so they got a high tooth. They hit it, and you get the signaling back to nerve pathways, and muscles are in spasm. Teeth get sore. Let's see if I missed anything else here. With what? In that, you can show horizontal and vertical bone loss on the radiographs. You can show widening of the PDL. No, it doesn't interface that way, no. You have to kind of do it, you know, you got the radiographs up and you can show them that and you can show them this. Yeah, in that sense. Yeah. So basically, that's the program. And as it turns out, I ended up going through all of these things anyway. Now, have we got 10 minutes? About 7 minutes. Let me show you one other thing. I got to shut out of this thing. I can't show it to you. Let me just encourage you to do this. Make sure you make Mark Piper's program on the last speaker. He is literally a genius. His CV is just fascinating, all the things that he's done. Any other questions for me? Yes. All you got to do is Google BiteFX, and it's going to come up. Yeah. And they're coming up with a newer version of this. This is about 1.5 years old now. When I was at the meeting, it should be out in another month or two. And it shows wear on the anterior teeth a little bit better. It shows mobility. There's just a lot of nice enhancements that they've done with this one. Yes. No, you can do up to 5 computers on it. Okay? Because that's my understanding, you can do up to 5 computers. No, multi-user. I've got it. I can have it in each one of my rooms. You know, I mean, I probably use it more in the consultation room than anywhere else. But like for an emergency patient, you know, I got a sore tooth. Here's the reason we got the sore tooth and why we have to adjust the bite on it. Because it show them it's hurting. Muscles and joints, but you can show them where they're at, and then you can show them the way that it should be, like I was showing you at the at the very beginning, the way a healthy mouth is, and the way those teeth should be, and where the bite should be. Not in this program, no. The new one is showing more of that. They're getting more into that because what they do is they just ask for feedback, and everybody's asking for that kind of stuff, so they're working it into it. Yeah. No, it does not run on Mac. I just have an iMac and a Pro and everything at home. Okay, but no, this is not Mac. Now I understand. I think he said that the new version coming out will be available for Mac too. But don't hold me to it. That's cool. I mean, it literally cuts down the immense amount of time it takes to try and explain things to patients. You know, there's a lot of patients who don't want to even know this stuff. So you got to read them, like we do everything else. You know, but there are times when they don't want to know it, and I say, you got to know. You got to look at this thing. This is really important for you because I know that it's a lot of money for you to do this, and I'm asking you to do something you really feel like you don't have to. But if I don't do this particular thing, I know later on you're going to have a problem. Okay, so you want to have your mercury fillings taken out. You want to have these crowns done on the lower left quadrant because the fillings are so large. Do I do it to the bite that's in error right now? Or do we consider doing it with an ideal bite? And what do we have to go to get to that point? Do you want to know about it now? Or do you want to just say, I'll just do the crowns? Well, most people will say, I'd at least like to know about it. Now, it may be more than they want to know, and so I'll tell people at the very beginning, when you look in your mouth, you've got a pretty good idea what's going on in the first 5 seconds. I'll say, don't get too overwhelmed by all the things we're going to talk about, but in order to give you a good diagnosis and prognosis of what we need to do, it'd be better if I had this information. And what I typically will do is after I do that, we'll go in a consultation room long before I've done the treatment plan. And what I'll do is again, notice I said again, ask them for what their goals are, short range and long range. So I know what to speak for. And then I'll give them an overview of the basic things that I saw. A lot of times they'll go, let me out of here. Other times they'll ask questions, and they'll ask questions, and they'll ask questions. And so with this, it just really cuts it off as far as how you answer a lot of those questions. It just makes it so easy for you to do. I'm telling you, this is worth a lot of money in treatment plan acceptance and doing good dentistry. And I think after seeing this, you can also appreciate what it would do for you. Yes? Well, I'm going to take that a step further. All of us have been here and done these things, and Matt, you know that this is the case. Over the years, I've always promoted do good dentistry. We've gotten better than the average, by far, than the average dentist, because a lot of what we're doing is rehabilitative work. And you better know where you're going to end up with these patients. Otherwise, you're going to run into some problems with them. But I can't tell you the number of times I've had patients come in and have cavitation surgery, and what it really is an occlusal issue or a TMJ issue. And that should have been taken care of non-invasively first, rather than the cavitation surgery. So you got to triage them and make sure you're telling them the right information. Now, I'm not saying they shouldn't have that, but let's rule out the obvious. And in a lot of cases, that takes care of it. Yes, sir. Absolutely. Absolutely. So thank you very much. Yes, one last question. Yeah. Well, and you got to make sure you tell them if you're doing the equilibration, you haven't gone through splint therapy or relaxation therapy for them, that's not going to be stable. You're going to see them in a week, and this is going to heal, and it's going to shrink, and it's going to move up, and they're going to be hitting on the back teeth. And it may take 2, 3, 4, 5 visits of just touching them up to really get it fully resolved. But you can do that. Thank you very much. I appreciate it.